All right, thank you. Our last panel for this year. Following this, we'll have some announcements and some introductions, but also we have one more presentation from a local organization called City Gospel Mission that we'll want you to hear. That'll be about a 10-minute presentation from them. We're glad they're here today. But I'm going to give a setup a little bit to this panel, what we're going to talk about. Innovation is something that, once you've innovated, and then if your innovation is great enough to become accepted and utilized, and it becomes the standard in society, is that still innovation? Now where do you go from there? So I think that any living, truly successful organization continues to evolve. It's never exactly the same thing as it was in the very, very beginning. And about 14 years ago, when Sherrill Morgan was really in the forefront of bringing forth new ideas, as I think you heard Mr. Weekman say in the one panel, he kept saying, when can I hire my own doctor? And not long after that, we found out ways to be able to put in health and wellness centers. It hits fire so big back in about 13 years ago that Sherrill Morgan's responsible for over 40 facilities across Michigan, Ohio, Kentucky, and Tennessee, which is really a unique opportunity that we've had that we've really enjoyed. Sometimes we just got paid to put one in and they said goodbye, and other times they told us to come and help them manage it on an ongoing basis. Even the two facilities here in Hamilton County, which we no longer represent, we were the real initial installers of those facilities there as well. So we believe ourselves to be innovators, but now the clinic organizations goes, yeah, okay, you got a clinic, or you can come join one. And one of the things we'll be doing in innovation in the coming years, like we have a number of groups that are many small groups put together, like Northern Kentucky Public Entity groups, which is like there's groups of 4 and 10 and 30 and 50 government agencies within that pool. Ways for them to be able to utilize one where they could use it on a utilization basis, maybe just pay as you go kind of situation. So the clinic space is evolving. We're going to talk a lot about that today and talk about really where it's going from here, because one of the big things that happened in the clinic universe was COVID. COVID just about put some of the clinic circumstances under, and others just kind of froze. And since then, now we're beginning to see a revitalization of clinics becoming popular and being utilized again, and becoming maybe even having more force and energy behind them than they did pre-COVID. But first, we're going to go down the line here. We have quite a diverse and a professional group of organizations here today. So 3 different clinic organizations. They've promised not to break out in any cage fighting or anything like that as we go through this. But and then we have one of our other partners here. So go ahead, go down the line and introduce yourself.
Good morning still to everyone. My name is Todd Fouché. I'm with PMR Healthcare. It stands for Premier Medical Resources. We are a clinic operator on a national basis and focus on both work comp injury as well as primary care. And our model is basically to deliver our services virtually, near site, on site, and more hospital community based in the last 3 years post-COVID.
Matt Hoff, I'm CEO of AS Medication Solutions. We provide medications and operate pharmacies, and when the fight breaks out, I'll be the referee.
Hi there, I'm Greg Bernacki. I'm the Chief Medical Officer for Care ETC, which is a company similar to the two that are on either side of me in the employer-based healthcare, and happy to be here. I'm actually an Ohio boy. I grew up in Toledo, Ohio, and I actually attended the Miami University, which is about an hour away from here. And I think I was at an AOPI function here when I was 20 years old for a dance, so good to be back.
So this is my third time up here on stage. This is on. Thank you. This is my third time being up here, so I'm not going to reintroduce myself. But I didn't tell you before something that you don't know about me. I can tell you in 42 years almost, I've been involved in treating patients, personally treating patients for probably 20 years. I've never billed a single patient. I've never billed an insurance company. I've never billed a patient. We'll talk about that later.
All right, thank you, gentlemen. I wanted to set up the first question is really just kind of resetting the groundwork of why the clinic space, on-site, near-site clinic space is even valuable or becomes so popular. Yesterday we had a gentleman by the name of Bill Banks on our panel, and he runs a hospital. St. Elizabeth's has the fortune of being probably one of the most profitable hospitals in Cincinnati. They are about a 4%, which was higher than any other unit in a facility in greater Cincinnati. But in conversations with him about primary care, he said, Mark, we thought we wanted to be huge in the primary care space, but we can't make any money at it. So they said, so we're not concerned anymore with external primary care because we can't make any money in the primary care business as a hospital. So they still support those, and it became a unique situation that the hospitals then started to cooperate with the on-site, near-site clinics. But gentlemen, to get to this question, and each of you take time to answer it, the reason we're successful is because something is broken. All right, what exactly in your feeling is broken with the regular primary care aspects to why we're then successful in what we're doing today? We'll start down there with Mike, yeah. Go ahead.
Starting with me?
Yeah.
Oh, I didn't know that was my question. That wasn't the predetermined question for me, but what's probably broken in a word. In a word, access. That's the primary problem, particularly in rural areas. Based on the number of physicians who go into primary care, it's pretty low because it's not one of the high-paying jobs to have after you graduate. So that would be my short answer.
I'll give you a little longer answer. So I'm a family practitioner by trade. So I've lived this. I graduated med school in 1985. So it's a long career of doing it. And the problems with healthcare now, or especially in the primary care, is one, there's no incentive for anybody going into medical school to go into primary care because it is any of the talking specialties, family medicine and general internal medicine, psychiatry, pediatrics, you don't get paid to talk. You get paid to do something to somebody, right? The way that the reimbursement is set up. So one, there's no incentive for anybody to do it. I'm kind of a dying breed, and you're seeing the rise of family nurse practitioners. My wife is a family nurse practitioner. They're wonderful. In my practice, before I came into this sphere, we had 5 nurse practitioners and only 3 physicians. So it can be done, but you're just having a decreasing base. Second is, if you're in the for-profit or not-for-profit world, you're being asked to do more with less. See more patients. For 20-some years, all I heard was, well, you can see one more patient. To go from 15 to 25 when I finally decided that was enough. And being asked to go from 30-minute appointments to 15-minute appointments to 7-minute appointments with less. So less time and then less qualified staff. So registered nurses, who were kind of a hallmark in primary care. If you were growing up in my era, there were always registered nurses in the practice. Now what do we have? We have medical assistants who are masters of everything with the least amount of training possible. So, I think that's part of it, which is, so you don't have as much of a supply. When you're seen, it's a very unsatisfactory experience because you're rushed in, rushed out. Some practices only seeing one patient for one problem and then out, and if you want to talk about another problem, we'll schedule another appointment. So, that's it, doing more with less and then diminishing supply, which then creates an access problem and a patient experience problem.
I would say it's disjointed. So if you were to go take your car into the shop, the mechanic is not going to say, well, I need you to go to AutoZone and get a carburetor, spark plugs, and some motor oil. They have it all right there. With medication, and this goes to Dr. B's point on access, if the doctor writes you a prescription, you have to go to a whole other place to get your treatment. Everything to me is drugs, but it's not the only part of healthcare that's like that.
Excellent. I heard the key word of access, and I believe we all are aware that access is an issue. Continuity of care is a great concern from multiple perspectives. There are a large percentage of the U.S. population that does not have a primary care relationship. There are a number of individuals that avoid care because they can't afford it. There's use of ER, urgent care, immediate care centers, where those entities don't necessarily talk to each other. But as I was hearing the comment, and I didn't want to miss the opportunity, but I would honestly say I want to sound the alarm. And the alarm is and just rhetorically, if I ask you the following, in my 40-year career, I have never experienced at the same time, right now, what we're living, is the shortage of providers, both at the primary care and specialty level. The health of the U.S. population, less healthier decade over decade to the present. So we have a high demand for services, but fewer providers to provide. So thus, what happens from a supply and demand is we have medical inflation at rates we've not seen. We have state and federal legislation that's going to take $1 trillion out of the public programs. Providers usually make that up on the commercial side, your side. And we have high deductible plans, which we all know why we had to implement those, but we raises a great question. Can I afford my copays and out-of-pockets? And my career currently is on the primary care clinic side, so we won't need a referee because I support fully what any clinic operator is doing. But to me, the question is no longer if you should adopt a primary care clinic model, is you have to. If you want to control your destiny, to be able to have a dedicated physician or mid-level that's working for your employees and family members, it's no longer a choice. The shortage is so great. And you can go on AI tools today and see what that projection looks like between now and 2035. It's not a pretty picture. So truly, if there's any motivation by you in the audience, join any of us up here, or Sherrill Morgan, or all, to identify how we address access, how we manage and connect the dots between your health plan and health insurance to address the continuity issues, the access issues, the large claims, the specialty med usage, all of it. And then from the prior conversation on innovation, there needs to be a forum for all of the new innovative tools to come forward. Our good doc here has talked about the shortage of time and relationship. So I apologize for the long-winded answer, but I really, truly look at you. This is an alarming situation that we're at. And as self-funded employers, you're in a great position of all sizes to be able to access these types of services.
Thank you. You know, it's and I know you guys. I know the answer to this question when I ask all of you, but it's just to illustrate to them, you know, the difficulty of the physician universe out there that are under most of the hospital systems and stuff like that, that are being forced to the 7-minute kind of universe. When the clinics have a physician come under their model, do you have any problem keeping them? No.
No, because you're offering a different environment. You're offering, you know, going out of a production model to just a quality model.
Yeah,
so no.
yeah. Our physician at my local clinic that I go to is newer there, and the words out of, and she takes care of my wife and I, and the words out of her mouth were, "This job saved my life," because they consider the primary care space, traditional primary care space, so arduous, so difficult that when we put out an RFP or a request for a physician, every physician that can usually responds to that situation. Now, we've gone, traditionally, you know, the clinics want to talk about their ROIs, and because they do have good ROIs, and because then I want to talk about how you measured ROI now or in the past, very briefly, because then I want to move from there where we got to go and all from that situation. So just very briefly, how did each one of you measure ROI in the past or today?
That's a very good question. You know, in order to calculate a return on investment, you have to invest something. In our particular model, they're all different types of financial models amongst the clinic vendors. In our particular model, we don't ask for an investment. We, at times, I say that, but we do ask that they provide the space, okay? And usually, I mean, it's particularly if it is a municipality, you know, they've got some space someplace, but it's not even a requirement. If you don't supply the space, we'll provide the space. We provide all the equipment. We provide all the furnishings. We you know, we recruit, we hire, we assume the salaries of all the providers and medical staff. And then what we do is we turn back around and bill it on an as-used basis. And so you're not really putting any money into it, and you're only paying as you go with our model. So how do you measure that? So the return on investment is probably up in the 100 to 200%. You can take what you're spending versus what you're saving. That's another way of looking at it. And the ROI is going to be, it's not going to be these little small numbers that people are typically associate with a good ROI. The other things that you would look at is the other types of savings, the savings that all of us tout, and that is the savings from the person not having to leave, for a 3-hour visit. And that's to get in and out of the doctor's office, and another 30 minutes in line at the Walgreens. And so there's a definite number that can be assigned to that. And it's not really, I don't know if you can say that you'll save, $15,000 a year per employee. It's more of the lost opportunity savings for an employee that would have been working during that time. So return on investment, just depends on the model that you have, and how much that the vendor asks you to put up front and on an ongoing basis.
So if you've seen one calculation of return on investment, or one methodology, you've seen one methodology. They're all over the place, right? There's no standard way to calculate a return on investment. As he was saying, you can do the softer target things. Yes, there's access. Your employee can come in here. There's less lost time. There's the whole retention thing, et cetera. But if you're talking to a hard-nosed CFO, he's like, doesn't matter, right, to the CFO. So then it comes down to hard dollars, which then you end up having to do a lot of analytical things. So there are a lot of studies out there that will show you that you can use that will show that, hey, better care, so taking care of those chronic disease states, equals better clinical outcomes, which there's a cost to, there are known things that you save if you get a diabetic, for example, under better control than if you don't. And then there are those things you can do with Matt and his group about what is your adherence rate? So are your individuals actually taking the medications that are being prescribed? Because statistics are terrible. 80% of the time that you see a provider, you receive a prescription, but only about 50% of the time is that prescription actually filled or taken to completion. So there are in the literature, what is your savings per disease state, per diabetes, per hypertension, per hyperlipidemia that you can do. So you can have some really hard target things to do. And then the ultimate is, if you get claims data from your client, you can then look at what is the cost within the clinic. What's the claim cost within the clinic versus what is the peer cohort that is being seen in the outside or in the wild, and what's the cost. And so, like I said, everybody will have a little bit different. The softer ones are the easiest ones to be blown off by a CFO, much more effective for somebody in human resources or people operations. But you literally have to, to me, I think in order to prove the value, which is awful, we all know it inherently that primary care has value, but to prove that to a numbers person, you better have some numbers.
So my numbers are a little bit simpler, but I'm a building block of what the guys up here are able to do. It's two things. First of all, it's going to be adherence rate. So you're going to be able to quantify how well the patient is actually taking the medications to get the outcomes that the doctors intend. And that is the building block of most everything else. Like Dr. B said, 80% of encounters are going to end in a prescription. We can directly influence that. The second thing is we can do a head-to-head comparison versus what the drug would cost if it went out to the PBM and out into the ecosystem. And being able to show those hard dollars, spreadsheetable savings compared to what the PBM would charge is a major way that even the most analytically inclined CFO can get on board with what we can do for savings. When we work on joint clients that are looking at putting a pharmacy in place, we've been able to show that our savings on the drugs is often enough to fund the pharmacy itself.
Yeah, we're going to go to a pharmacy discussion here right after we're finished with this segment here to go deeper into depth of what we can do in that pharmaceutical universe.
On the return on investment side, I think to my peers' comments, we all intuitively can see the value of access and early detection in that, but to the point, almost every employer we serve wants us to show them the numbers. So we will take an employer's data file, identify of the total spend, what realistically of that spend could have been provided in a on-site, near-site clinic setting, and then line by line on a quarterly report show exactly what codes were provided in the clinic, what you would have paid through your TPA or ASO, and what that unit cost differential was through the clinic pricing. But more importantly, where you are spending more of your money is on that specialty surgical hospital side and special meds. So our model has expanded on how do we bring the specialist into the clinic discussion, how do we bring the hospital to the table, how do we include the specialty medications that we source domestically and or international, depending upon your tolerance. And it's through managing it through the primary care clinic, that higher dollar spend, that we will report back every unit cost differential, every referral to a specialist or hospital that was a direct contract, what you're paying under the direct contract versus what you would have paid through the hospital. Specialty med side, what you're paying through the PBM for specialty meds, what you are paying for them through the clinic. And then on the work comp side, for those of you who are in those industries, we will identify how much of the care we've kept into a first aid category that doesn't become an OSHA recordable event. What is our return to work efforts? How many off days, lost days of productivity did you gain by the clinic helping to get the employee back to work? And if you add up all of those unit cost differentials, the impact on specialty hospital, what we do on the work comp, the ROI becomes much more objective from the CFO's perspective. So it's all of the above, but it's a very labor-intensive process to cross all those T's.
Yeah, so an evaluation of clinics originally being a major innovator in our communities and our health plans, what were the innovations that came along? Now we're moving forward to new ones. In the very beginning, it was very big in the work comp space. It was like, we're going to take those work comp situations for you on an employer basis. It became then an urgent care facility for urgent care needs or emergent care. And now it's a primary care model, and really the primary care model came into being about a little over a decade ago, where it was the predominant model that primary care was being offered on an employer basis. Innovations that came along with that were deemed innovations at the time that were just like, how they do that was when there wasn't a high deductible plan involved, charging no copays for your employees, that they could go and not have to put any money down when they go. That was a big deal. That they would get 15 minutes or maybe longer with the physician, that was a big deal. That was an innovation back in the day. The ability for the physician to hand you the drug into your hands so that you don't have to go to the pharmacy to get that drug, that was innovation, but yet that is even going to evolve further to not be able to handle those generic drugs and get them to you right away, but through the beginning of new models and new partnerships, it's going to expand over the entire pharmaceutical universe. That can be done through a pharmacy, could begin to evolve to be used, and even going into other directions, we'll talk about some, such as what the innovations they could do, pharmacy, infusion centers, have infusions done. The margin on infusions is significant. When we talk about that, you can do 3 infusions a week in an infusion center and save enough money to pay for the whole center. That's how much money is in infusions. So then to try to change course, and we'll have Matt and the doctor have a little conversation briefly, because they're now partnered on pharmacy with Sherrill Morgan in Memphis, and with our school systems down there. We're about to open the doors on a second one and all, but why don't the two of you just, first of all, it's brick and mortar. It's owned by the employer group, so they own it, and it's so unique that it's even benefiting other customers of ours. But Matt, why don't you go ahead and start and talk about that?
So I'm going to pick up on Mark's story, and if you go back to where he was talking about, where employer clinics started, were really avoid the work comp claim, then it moved into urgent care. Very low cost medications. About a decade ago, the innovation came into place of these really can become primary care homes, and those homes can get the medications directly to the patient. They can do that on site, and they can do that with mail order. So when we first started this MSSC pharmacy evaluation with Mark, the MSSC was already doing those things. They had a wonderful dispensing program, they had a wonderful mail order program. But the secret thing here is the medications that were being carried were very low-cost generics, or mostly low-cost generics. So while we were having a tremendous impact on patient satisfaction, on health outcomes, our financial impact, while significant, was only scratching the surface of what it could be. So Mark and my dad, we're both second generation in the business, came up and said, look, if we put a pharmacy in place, we can start taking in medications that are written by prescribers outside of that primary care universe that's captured on site. And if we're saving 8 to 10% on atorvastatin and metformin, that's pennies and dollars. If we're saving that much or even more, which we've proven, on Januvia, Jardiance, GLP-1s, Repitha, these medications that are hundreds and thousands of dollars, that's a significant amount of money. That's hard dollar savings on every claim. The best way to do that is with the brick and mortar pharmacy, because not only are you getting that pricing advantage, you are bringing the patient who is already engaged actively with a specialist outside of the clinic back into their medical home. So while there is a savings there on the drugs, bringing them into the ecosystem and letting the doctors get a chance to work with them on a primary care basis, we actually are serving as a carrot that brings folks into the clinic, in addition to having a really significant financial impact. And I'll turn it over to Dr. B.
And Dr. Bernanke, the clinic and the pharmacy in Memphis are actually right next to each other. You know, that's
Yes, very, very convenient if you can see your primary care and come in. But Matt said it very well, where just like, and when we were talking about referral management, the big cost in medicine is not necessarily in your primary care office. It is in your specialty and in those that do not take access into the clinic. So the client has literally no control over what is being prescribed. So if you can have a brick and mortar pharmacy, and you can then allow those drugs that are being written by outside folks, the outside PCP or the outside specialist, and start hammering away at those high dollar costs, then you really can have savings. And it's synergistic, because if they come to fill the pharmacy, they're like, what's that? That's your clinic. Would you like to establish as a PCP? So it's very synergistic.
I think one of the, and I know everybody is like a couple hours from Oktoberfest, and you'll need a beer after I say this, but we talked about GLP-1s yesterday and the impact that those drugs have had on everyone's spend. And the thing that's going to make you need a beer is it's not done. There's more iterations of those coming out. There's new therapeutic classes and anti-dementia. You are going to see in the next 10 years these extinction level events hitting pharmacy innovations, and having that pharmacy there, that's what's able to help control for what's next, because you'll have Michael and his team that are working with your primary care provider to make sure the things that are coming in from outside of that ecosystem make sense and the costs are being mitigated as best they can.
I think too, when I think you've got the clinic and the pharmacy tie, what it does is it amplifies what the real purpose of the primary care facility was to begin with, and that was to improve the outcomes of the patient. Because historically, when we first started doing this, we could put in a physician's office and run it, and we knew we were going to operate at a better, lower dollar than the physician universe out in the community, because we could buy our labs for cheaper, we were dispensing these very inexpensive drugs, and we paid our docs by the hour rather than by CPT code. Since COVID, that's become a little more difficult. The compensation, as Todd was saying, that is throwing out the alarm. Doctors are fewer, and we're having to pay them more. Right now, the clinic industry still is operating at a better dollar per unit than the universe is, but the margin's closed. So the greater importance of what is the ultimate outcome of the patient? How are they tracked? How are they followed? How does it become a true medical home? But because they're not owned by any particular organization other than the employer, now we can explode that ROI again financially, because they're beginning to realize that their ability, the physician's office's ability to control the formulary and dispensing and prescribing methodology to the patient, and how that raises, just amplifies that ROI on a dollar basis and on an outcome basis. So that, in my mind, is a real evolution, innovation, just going to change how healthcare is delivered going forward. And you know, I think, Doctor, you may have had one yet, but we're still yet to open our first infusion center. But I think that we'll be doing more of that in the future. But just describe what one is for the member real quick.
We're looking at multiple infusion solutions, because, as you know, as was said earlier, there's one drug, Ultomiris, which is $250,000 per infusion, and you're giving it 4 times a year. So that's $1 million of spend that if the cost can be cut, again, you can finance your entire clinic through infusion. So we're looking at infusion centers, but we're also looking at infusion in the home. Which also then decreases cost if you can divert somebody from a rheumatology office that is doing their own infusions, which I'm not quite sure how Stark law is avoided in that, where you can refer into your own center and charge for it, or from the hospital, where these are all profit centers for them, and then take it into the home, which is more convenient, and then also is a cost savings, not just on giving the infusions, because you don't have the facility fees, but also on the discounted medications or the discounted cost for the medications. That this is going to be huge in the in this employer-based healthcare sphere.
And I have a question specifically for 2 different questions, one for Mike and one for Todd. Mike, you mentioned earlier, you referenced earlier, you're doing something really so simple that the industry has not done in totality yet. And that is simply created a model where it's a utilization, pay-as-you-go model. I mean, the power of that within a community and collaborating is huge. The simple thing that you're doing, can you just talk about what that's meant for you and all?
It is actually pretty simple. It's the same model that I used back. My previous company, the name of it was TMS, Therapy Management Services. And so when I said we never billed a patient before, it's always been, you're our host, we're your vendor, we are providing you a service. It was rehab services at the time, and it was pay as you go. We provided all the equipment, all the employees in the hospital worked for us, all the employees in that department worked for us, and we billed as used. And so we use that same model. Now I'm using that same model with Symbol, where we're not asking you to put up capital. We're asking you just to pay for what you use. It's a no-risk model, and I don't know why it doesn't sell like hotcakes, but there's always competition. We love competition because that's what makes the world go around. But it's pretty hard to leave a meeting and because I think what they'll do at the end of the day, if they're taking a bid from 2 or 3 different vendors, which is the usual course, they're going to look at that down at the very bottom, okay, and then and whoever's got that lowest price at the end of the day, I think that's what employers are looking for. How you get there is another thing, and we're often asked, how can you do this? Why would you take the risk of telling them they will only pay as they use? And my most common answer is because I know they'll come. And why will they come? Because they come because they know what kind of care that they're going to get. You have one chance at when a patient comes in. I think you really have one chance, because if things go sideways in that first visit, if you don't match up the provider to the environment, I wouldn't hire a gerontologist, a doctor specializing in geriatrics, necessarily to work in an industrial plant that makes rebar from scrap metal. You have to pair that provider up, and so if you're confident in what you know you can do, and you're willing to take the risk, and I've been doing this particular model for so long, it's been very successful.
Yeah, I think that what it means is that groups of 100 that might be self-funded, or 50 or 60 or 300, be able to pull together to share a clinic, because you're no longer bearing the risk of that initial opening, that initial operations. That in itself, even though it's just a business model, is an innovation of how the industry has operated in the past to make it more accessible to smaller populations that can come together. And now, the gentleman next to me, when he first told me what one of his niche situations was, I said, "Man, you're crazy." But partnering with hospitals and working with hospitals is what Todd does very, very well. We actually have a hospital customer that we partner with on that. Todd, why don't you talk about how that makes you unique in your hospital relationships?
In the situation where you have the smaller employer that may not be able to justify a clinic on a standalone basis, is many of the employers we work with in rural communities, or most communities, are of that size. They're under 500 lives, or those who are over 500 lives. But our first approach to the hospital was that if they could provide the brick and mortar, it was one less decision that the employer had to make about where the space would be. At the same time, we very quickly learned with the CEOs of the hospitals is they totally did not understand the employer objectives. They were so diametrically opposed. So what we know is the hospitals need market share. We know many of them are in financial straits. We know most of them lose money on primary care. Well, that's a real issue. It doesn't serve any of your communities for the hospitals to close or to have financial issues of this nature. So how do we start the dialogue where they're educated, and how do we get them in the room with the employers to have a conversation? And most of you ask yourselves, have you ever been in a room with a hospital CEO to have a discussion about what you're trying to accomplish and what they're trying to accomplish? Well, there is a way to moderate that discussion, bring the two together, provide the brick and mortar, allow the smaller employer to have access. But we, PMR, are an independent that manage the physician team. We're not owned by the hospital, so the patient can still have open access and go to any physician that they choose, or they have a patient-doctor discussion about where is the best outcomes, where is the lowest cost, is there a direct contract in place, and the physician and the patient decide where that care is going. Well, when we approach communities of 50,000 residents or 100,000 residents or 200,000, it was much easier to get the hospital and the employers in a room together. And then we use those as case studies to show the next 100,000 life community how you can bring the employer and the provider community together to address the issue. Then we bring the specialist into the discussion, and it just keeps evolving from there, and use one case study after the next. We're helping the hospital reduce their loss on primary care. We're providing it. We're helping the employer understand through reporting exactly what the unit cost savings is and what the big dollar savings is. We're helping the hospital earn more market share by getting more aggressive on their pricing for the market share. What if it's zero deductible if I come to your 5-star facility versus whatever it happens to be? It's not like Anthem's walking in and telling the hospital, you're going to do more for less, which is pretty much what that conversation looks like. We're walking into the hospital with the employer arm in arm that says, we'll steer our patients to you if you earn our business from a quality perspective. Are you willing to sharpen your pencil below the network contract rates that I'm paying today? And when the hospital sees what the benefit is to them, what the employer sees the benefit to them, it's a win-win. That's what we're trying to accomplish, is the win-win. And the clinic is the forum for starting those conversations with our producer partner.
Thank you. Matt, we'll close with some questions with you. Yesterday you were part of a panel where we talked about brick and mortar pharmacy. And now we're talking about partnering those with your clinic. But I think some of the things one of the things you mentioned yesterday was, first of all, one of the ways we save money is just because we're eliminating so many
Middlemen.
Yep. Can you talk a little more about this briefly about, that's actually a significant spread in there.
Yeah, so the pharmaceutical supply chain is very complicated, and if you've seen the discussions that have been going on about how do we actually take down drug costs in the US and why there's so much confusion, it's because there's a lot of smoke and mirrors and shadows and obfuscation there. So really simply, if you look at the life cycle of a drug, after all of the research and development is done, and about 95% of everything they try never even makes it to an FDA trial, and probably less than a sliver of a 1% actually turns into a commercially viable product. So these pharmaceutical companies have all of that overhead they need to try to offset. And then meds are made overseas with a number of different chemicals that come together to create a drug. They're generally shipped to America, go to a manufacturer, to a wholesaler, to a pharmacy, to you, and then there's this thing called the PBM that lives out there that decides what you're actually going to pay. So the cost of a drug, if you compare it to the cost of any other product, a computer, an iPhone, something like that, it makes sense all the way until that PBM portion. So when you're taking out as many of these middlemen as we're able to, the wholesaler, the PBM, the pharmacy, not only are you taking those folks out, but you're taking out people who have an incentive to be able to adjust what the costs are or create reference-based pricing like AWP, which the joke is stands for what's paid, or MAC or NADAC or any of these other prices. So when you look at trying to set a most favored nation price, well, the US can already get drugs at the same rate anybody else would. It's called 340B. Getting that so that it's in everybody's hands with the constraints that are around the system, that's something that we really try hard to get across.
And I'm glad you said that. Used to be the unicorn, everybody wanted to get 340B pricing. And I said, yeah, that's the unicorn. Everybody wants one, but you can't find one. Well, now today, because of the brick and mortar pharmacies being owned by the employer group, we now can be qualified to get 340B pricing. The Memphis pharmacy is going to be qualified for own use pricing. So our school systems would be a drug on an own use basis, which is another qualification on a broader basis. So the world is changing fast. If you're thinking about a clinic, I think you should think very seriously about it, or partnering with one that already exists and joining that. Real quick, if anybody has any questions at all. Yes, sir.
Thank you. My name is Eric, and I'm from TopMD Health. I have two questions. The first one is speaking about ROIs for the clinics. So, and Todd, you mentioned that primary care is one of the ways how the hospital is losing money. And there are like many telehealth providers, such as a Teladoc, MD Live, Doctors on Demand. They offer quite low, pricing for the primary care doctors. So what are your thoughts on maximizing the ROIs for the clinics using the telehealth providers in the US or even globally?
An initial thought that comes to mind is that from our perspective, telehealth is very much a service that we complement the on-site visit with. But what we see as a key difference, or what we feel an employer needs to consider, is that telehealth may provide access, but many of those telehealth visits are not about disease management services. Each time you call a telehealth provider, great service, once again, there's a need, there's a reason for that, for using telehealth, but those are generally going to be for immediate care type issues. If I've got, in America, depending upon what source, 64+% of us have one or more comorbidities. Well, I need face-to-face time with a doctor, so it's really about complementing the two. So if I looked at you and said, in our clinics, 58% of our visits are for managing diseases. What's the root cause of the issue? And versus just medication that masks the symptom and we go forward. So it's a complement between the low-cost telehealth to provide access for a lot of the immediate needs that take place, but complementing that with an on-site, near-site strategy where you can manage the disease states and access the innovative services that we talked about earlier, or to take advantage of all of the other direct contract arrangements to affect the care that's referred out of the clinic. So it's a complement. We're not going to do anything in the clinic that's going to be lower unit cost than a telehealth visit, but what we're doing in the clinic is focusing on disease state, not always just the urgent matters.
I completely agree with what he was saying in that it's a quick hit visit. It's not the same provider every time. It is taking care of the immediate need that you have right now. And as I tell people, sometimes you just got to touch a patient, right? So it's not enough to just see them on the phone. If you have an abdominal pain or something, you'd have to do an exam, and you can't do that over the telephone. We haven't figured that one out yet. As well as we can't do the preventive services over the telephone. You can't do a colonoscopy, you can't do a prostate exam, can't do a breast exam, all of those things. So, to me, I think you get what you pay for on the telehealth experience, and in a lot of health plans, it's thrown in, or it's $1, per member per month, or $2 maybe, but that's what you're getting. And if you look at the patient satisfaction with a telehealth, just any of the commercial telehealth vendors out there, patient satisfaction is terrible. So it has to be in conjunction. To me, we do a lot of virtual care, and in fact, we're starting to offer a virtual primary care offering, but it's going to be with the same provider. And we also have all the off-ramps of, if we're providing in this area, what's our off-ramp if somebody actually needs to be touched? Where are we going to refer them into? So it's good for short, not good for chronic disease management.
Thank you. And the second question is related to the opening of our own clinic. So what would be the size of the site should be there to make sure it's bringing good ROIs? If it's or what kind of should it be specialized on different care? It could be like wound care or any other specialties. What size of the clinic, square feet, you would recommend to have? Like if we have a prime location at San Francisco in downtown, so what would be the size you recommend to have?
Our patient to doctor ratio is about 1,400 patients per doctor. That generally we operate in about 2,300 square feet. So the patient base that we're looking for, if you're an employer that's 100 employee lives, you might have 250 people on your health plan. So we're looking for other employers in that vicinity to come together, create that 1,400 patient base to where we can maximize the economies and help all of those employers not only receive the services, but then capture the unit cost and the other specific objective savings to report back. If we have a clinic in a hospital, it's easy to get 100 life groups to join a facility that already exists. We'll go in and we'll set up brick and mortar in a community and then market that to the employers of all sizes. But for us, the key is how do you use the physician team as efficiently as possible? It takes about 1,400 belly buttons, so that's including dependents, in our model, and about 2,300 square feet.
All right.
Thank you.
And in Greater Cincinnati, we have the Greater Cincinnati Health and Wellness collaboration of 4 facilities on both sides of the river. And you can apply to be a member of that organization as an employer simply by contacting our office. And all you have to be is self-funded. And in fact, I'm sorry, you don't even have to be self-funded. We have a number of law offices, including my office, that are not self-funded. And there's a unit cost that you can pay for your employee on a monthly basis to be able to use the facilities if you wish to provide that kind of concierge service. Having said that, thank you, gentlemen. Appreciate it. All right. I'm going to stay up here because we only got